Welcome to this video. Today I will be speaking about the initiation of insulin in patients with type 1 diabetes. This has been a very popular request, and therefore I can agree it's very important to know. This is something that isn't taught properly or at all in many professional schools. So in this video we're going to cover how to determine the total daily doses of insulin that is required. We're going to cover something called carbohydrate counting. We're going to look into what's called a correction factor, and both the carbohydrate counting and correction factor are respectively giving insulin to cover a meal and giving insulin to correct when the glucose level is higher than it should be. We're going to look at how to adjust different insulin dosages, and we'll have a few examples. So a bit about myself. I graduated from medical school in the United Kingdom. I'm currently finishing my thesis in endocrinology for my master's, and I'm also finishing a thesis for my master's in diabetes. I'm also a member of the American Endocrine Society. So let us jump into it. We need to understand a bit of history before we go into what insulin is, how to calculate it, etc. So if you remember anything from this lecture, remember one year in particular, and that year is 1922. Every Canadian is aware of this. Myself, I'm Canadian, something we're always taught about. That's the University of Toronto. Specifically about it, this is the year when insulin was actually extracted from Marjorie the dog by Banting and Best and successfully given to Leonard Thompson, who was a 14-year-old boy with type 1 diabetes at the time. He went on to live for 20 plus years afterwards because of this life-saving treatment. Soon afterwards, Eli Lilly and Company began manufacturing insulin, and it wasn't long before the Nobel Prize was awarded. Quite ironically, and 100 years later, almost nothing has changed. Charles Best was not appreciated, only being a medical student, and he wasn't given the Nobel Prize. So if we go a bit more into the history, we can see that over the years, we slowly moved away from animal insulin. We then went to human insulin in the 70s. By the 90s and 2000s, we were creating analog, which is a laboratory modified insulin. So if we look at this graph, we see there's quite a lot of difference between these varying types of insulin, and it can seem quite confusing. And in essence, it is supposed to be confusing. It's not supposed to be all the same. So if we look at the green and the red, we see there's rapid acting and short acting insulin. And these seem to peak quite fast, and within a few hours are out of our body. And this is very important. We give these before a meal. They're known as bolus or preprandial insulin. And these are used to cover the carbohydrate content in the meal, or as I mentioned earlier, the correction factor. So if we look at the blue, the pink, and the orange, we see these are either intermediate or long-acting types of insulin, and this is known as the basal or background insulin. And what this is important for is the in states of fasting when we're not eating, the background insulin that's always there to prevent the formation of ketone bodies. And it's the same thing if someone were to go on an insulin pump, they'd have a background basal rate, and then they'd also have the bolus insulin for when they're eating. It's always important to remember we're constantly producing insulin. It may just be at differing levels depending on many factors. So if we go into this graph in more detail, we can look at the varying classes. So if we start with rapid acting insulin, you can see there's different types. They're all slightly different, but overall they're quite similar in terms of their onset of action within about 20 minutes. They peak within 1 to 2 hours, and by 4 hours, the duration of action has finished. So with rapid acting insulin, we recommend to give it about 15 minutes prior to a meal. That way the onset of action will coincide with the commencement of the meal. Epidura is actually a rare exception where the FDA has approved for it to be administered up to 20 minutes after a meal in pediatric patients. However, of course, the efficacy isn't as great compared to when it's given 15 minutes before a meal. I've put something called Afrezza here in its own category. It's still a type of rapid-acting insulin, but it's actually an inhaled insulin. And as you can see, the onset of action, the peak, the duration of action is quite similar to the above. This isn't used too commonly. It's difficult to find physicians willing to prescribe this. And that's very much a lot of physicians, myself included, tend to think insulin does not belong in the lung. Insulin is a stimulatory molecule. We don't know the effects it's going to have upon the respiratory tissue. So if we go to this short-acting class of insulin, we can see there's the regular insulin. And as we've said, rapid-acting and short-acting insulin are what we give before a meal or to correct when the sugar's a bit too high. Regular-acting insulin is similar. However, The onset of action, as you can see, is a bit longer compared to the 20 minutes in rapid-acting insulin. It's about 30 minutes to an hour in the short-acting insulin. It does last. It does have a peak a bit later as well at 2 to 4 hours, and we can see it does last a bit longer in the system. So when using this type of insulin, there's a higher risk of hypoglycemia. Um, we should note, however, that when a patient's admitted with diabetic ketoacidosis in the emergency department, regular insulin is the only type of insulin that can be administered intravenously. So this is the type of insulin they will use. We can see there's something here that says that's called the regular U500 insulin, and we recommend patients go on U500 insulin when they're requiring 200 or more units of insulin a day. Basically, U500 is 5 times as concentrated as U100 insulin, and this can be used, as we see, as a pre-meal insulin, but because of its long duration of action, it could also be used as a background insulin. Again, it's very difficult to calculate U500 if you're not trained in this manner, and it's best left for the professional. If we move on to the intermediate category, we see NPH, and this is a basal or background insulin. As we can see, its duration of action is only 10 to 18 hours, so it's given twice a day, typically 2/3 of the dose in the morning, 1/3 at bedtime. It's important to note because of this twice daily administration, there's a much higher risk for hypoglycemia, that is low blood sugar, and it's therefore not typically recommended unless perhaps insurance is only willing to cover it or the patient is uninsured, and this is much cheaper to afford on their own. If we move on to the long-acting category, we can see there's many different types, and there's subtle differences. If we look at Tresiba, also known as degludec, we see there's no peak. If we compare that to Levemir, there is a peak at 68 hours. Again, looking at Tresiba, the duration of action is about 40 hours, so it's clearly once a day, whereas the other ones, the duration of action may differ a bit, and sometimes the other ones may require twice a day, depending on how many units of insulin are required. So again, we've already said most of this, but there are subtle differences within each category to be aware of. So it's important to have an understanding of the insulin physiology. What are we trying to recreate when we administer and prescribe insulin? So in normal circumstances, insulin is released from the beta cells of the pancreas in a place called the islets of Langerhans, and this is released straight into the portal circulation. In type 1 diabetes, antibodies are formed and destroy the beta cells. We're not entirely sure of the reason for this. Perhaps that'll be another video topic. So in type 1 diabetes, insulin is necessary for survival. Patients will continue to be in a catabolic state and will die without insulin. When we administer insulin, we give it subcutaneously as an injection, and that goes into the peripheral systemic circulation. There are a bunch of factors we need to think of that may alter the absorption of insulin. When there's a change in temperature, for example, if it's very hot, our blood vessels dilate, insulin is more easily absorbed. The opposite, when it's very cold, our vessels constrict and it may take longer to absorb. Similar with exercise, we overheat and insulin may be absorbed faster. The site of the injection is important. We need to administer it somewhere where there's a lot of fat, preferably on the abdomen, and we rotate to avoid the same site, which can cause thickening of our skin or lipohypertrophy. And again, we need to look at the timing of the injection. Are we giving it the 15 minutes before a meal? Are we forgetting? It's also important to know that many of the varying insulins on the market just have a natural differing bioavailability or how much of it will be absorbed. So we see insulin has multiple important functions, either inhibiting or promoting, but most important to know, when insulin's in the system, it prevents the formation of ketone bodies, and it's the ketone bodies which is what is seen in diabetic ketoacidosis. We also know that insulin promotes the uptake of glucose into the cells. So let's talk a bit further about how to initiate insulin in type 1 diabetes. So you'll see something over and over again called TDD, but it's actually quite difficult to find. What does TDD stand for? So quite simply, that means the total daily dose, or the total daily dose of insulin. And most of the guidelines recommend that 0.3 to 0.5 units per kilogram of body weight is how much insulin a day we need. Again, this is referring to someone who has type 1 diabetes who does not produce insulin. It's different in type 2 diabetes, and I'll be making a separate lecture on that very shortly. There's an important consideration whether it's 0.3 or 0.5, and that really depends on how sensitive, how frail, how likely they are to respond to this. For example, if we have a patient who's just newly diagnosed with type 1 diabetes, uh, we don't want to overtreat it and throw them into hypoglycemia. So we start low and go slow, as they say. So we would think about giving 0.3. Another consideration is when someone's diagnosed with type 1 diabetes, there's a period where the remaining cells in their pancreas that haven't been destroyed are no longer quiescent. They begin to wake up. And this is known as the honeymoon period. The honeymoon period is when all of a sudden they're going into frequent and repetitive hypoglycemic episodes because the insulin they were adjusted on is now too much for them as those cells are beginning to recover, the ones that weren't damaged. So sometimes it's best to start low, but again, it does depend on on the individual patient and on the physicians you work with. Again, insulin is actually metabolized in the liver and the kidney. Most of it is in the liver, but if there's kidney damage, for example, or if there's liver damage, it's going to take longer for the insulin to be metabolized and excreted, and therefore you might want to start with a lower dose because the insulin would stay longer in the system. Again, if it's a very small, frail, older individual, we might think about giving a lower dosage. If a patient is very, very resistant, and this is usually after many, many years of administering insulin, they might require a higher dosage, sometimes 0.5 to 1 unit per kilogram body weight. Typically, if they require more than 1 unit per kilogram of body weight, we know they have quite significant insulin resistance. You may think they have something called double diabetes, where it's type 1, where they've also developed resistance, and it's more or less a mixture. But let's not worry about that for now. Let's go to an example here. We have a 21-year-old who has just been discharged post-diabetic ketoacidosis. He weighs 72 kilograms. Most people would immediately start on 0.5 units per kilogram and provide a glucometer, and the patient's advised to frequently check their sugar levels throughout the day and adjust it as appropriate. So if we do 0.5 units per kilogram and he's 72 kilograms, he has a total daily dosage of 36 units. And we like to divide this, about half of it is basal, or background, which is the long acting, and half of it is the bolus, or preprandial before meals. Sometimes it's about 40-60, it really depends, and it is a more trial and error approach. As we see here, 18 units becomes long acting, 18 units is before meals. Now it's really important to know, and multiple choice questions love to trick students in this. It's not 18 units before each meal, it's 18 units covering all 3 meals. So that would be divided across 3 meals, so 6 units before each meal. And again, this is just an estimate to how to start someone at first. It becomes trial and error after looking at their blood glucose readings, their blood sugar log, we are able to fine tune it. It's important to note the American Diabetes Association, or ADA, their targets. They recommend that a preprandial is 80 to 130 milligrams per deciliter. A peak postprandial, so up to 2 hours after a meal, should be less than 180 milligrams per deciliter, and the HbA1c, or the 3-monthly estimate of glucose, to be less than 7.0%. So let's just look a bit about some hypothetical examples. What we see here is there's insulin, which seems to be delivered right before the meal, in this case a piece of toast, and the meal is eaten 15 minutes later. We see beautifully that the blood sugar rises to within the range and over the next few hours goes back down, all staying within the appropriate range at the preprandial and the postprandial state. If we look at this example, however, although the insulin appears to be given before the meal, after a few hours it appears the blood sugar has dipped too low. So in this case, we might think perhaps the insulin they have been administered is too much. Perhaps we need to be a bit stricter with their insulin dosage. And here we see the opposite, where they've administered the insulin before the meal, but the glucose has continued to rise afterwards, so perhaps that's not strong enough. And one final consideration here is when insulin is given right at the time of the meal, they will spike. It will come down as the insulin gets into a homeostatic state alongside the blood sugar, but it does have that peak, which is not what we want. We want the sugars to be within the range. So further intensification, as we've said, 0.3 to 0.5 units per kilogram at first, but we then fine-tuned this. So this was what we originally recommended, 18 units of background insulin and 6 units before each meal. There's 2 further important concepts we need to know. One of them is known as the I to C, which is the insulin to carbohydrate ratio. And quite simply, what this is how much will 1 unit of how many grams of carbohydrates does 1 unit of regular of rapid acting insulin cover? So the formula for this is 500 divided by the total daily dosage. 500 because this is the average of what a person will consume in terms of carbohydrates, as well as what the own liver in the body will produce. So 500 divided by the total daily dosage of insulin. And in this case, that's 36 units. We have about 13.88. Some people like to round down, some people like to round up. Really, again, depends on the physician you're working with. But this would suggest 1 unit of rapid acting insulin will cover 14 grams of carbohydrates. And patients can use this then. So when they're eating a meal, they see how many carbohydrates are in that meal. They then use this for much more accurate results. As we see going back to the previous slider on the top of this page, where it's 6 units before each meal, that's not the most accurate and best cover of the glucose. That's more of an estimate, but this is a much tighter and closer module for preventing the hyperglycemic spikes. Another important concept is the ISF, which is the insulin sensitivity factor or correction factor. And quite simply, what this means how much will 1 unit of rapid acting insulin lower the serum glucose. Now, here it says 1800 divided by total daily dose. It's important to note this is 1800 if you're using the American units, which is milligrams per deciliter. If you're using the British units, which is millimole per liter, this will be 100 divided by total daily dose. Going back to the left side of the screen, 500 for the carbohydrate ratio is the same within America and Britain, so don't worry about that. But going to the right hand side, 1800 in America. So 1800 divided by 36, we get 50. And this means 1 unit of rapid acting insulin will lower the serum glucose by 50 milligrams per deciliter. And this is important when we need to correct our sugars. There's a few other things that we should be aware of. This 1800 is specifically for rapid acting. When you're using regular insulin, the short acting insulin, we use the rule of 1500, which is 1500 divided by TDD, or total daily dose of insulin. Okay. Now, although 1 unit of rapid acting insulin, as in this example, will lower the glucose by 50 milligrams per deciliter, we don't want to always give it. Specifically, what if the patient had a glucose of 50? We don't want to give that and they would plummet to 0. So we typically recommend over a certain level, they give a correction factor. Commonly, we'll see over 150, they should give a correction factor. So for example, 50 milligrams per deciliter is what will be reduced by 1 unit of rapid acting insulin if the sugar is over 150. And again, we need to have an individualized pre-meal target. Most healthy patients will recommend that their preprandial sugar level is 130 milligrams per deciliter. Okay, so that's very important. A few other things I'd like to mention regarding this slide. Going back to the left-hand side, although it's 500 in America and in the UK, certain guidelines are now considering switching to 450. Seems to provide a better estimate, and this is something the ABCD guidelines in the UK are recommending. For the most part in America, it seems 500 is still used. Another thing to note is that the insulin to carbohydrate ratio does vary throughout the day. We're usually more resistant in the morning as we have the counter-regulatory hormonal response, and therefore it's not uncommon that you'd see different ratios throughout the day. An example being 1 unit to cover 8 grams of carbohydrates in the morning. By lunchtime, that's changed to 1 to 10, and by dinner, that's maybe 1 to 12 or 1 to 14. Okay, so that's very important to know, and that's something we see with insulin pumps. We program the the carbohydrate ratio based on the time of the day. Now, what this slide shows is, as I've mentioned, the importance of giving a correction bolus at the appropriate time. If we just look on the right-hand side of this graph, we see the patient realized, oh, my sugar is high, I should give a correction bolus. But no, it shouldn't be given within about 3 to 4 hours after a rapid-acting analog has been delivered. It should be given only before meals if the pre-meal sugar is higher than it should be. So we don't want to push patients into hypoglycemia. So a bit more about the carbohydrate ratio, there are other ways of estimating it or calculating it. Again, it's more of a trial and error approach. We can either do it based on how much insulin they require per day or based on their weight. Um, these are different examples you may see from various guidelines and textbooks. If a patient's requiring a certain amount of units on the left side of the screen, we have an estimate for the insulin to carbohydrate ratio. And again, on the right hand side of the screen, depending on their weight in kilograms, there's also an estimated ratio. Again, this is very individualized and it's trial and error. So now let's jump into a case study. So the previous patient we were discussing is about to consume a meal consisting of 50 grams of carbohydrates for lunch. His current blood glucose is 190 milligrams per deciliter. We know his pre-meal glucose target is 130 milligrams per deciliter, and his insulin to carbohydrate ratio is 1 to 14. We also are given that his correction factor is 1 unit for 50 milligrams per deciliter. So how much insulin would this patient require before his lunchtime meal? So considering how many carbohydrates he's eating and what his current glucose is compared to what his target should be. So there are three ways of answering this to get slightly different responses. If we had the prefix dosages, which we calculated at 0.5 units per kilogram, we know that he takes 6 units before each lunch. And if you're just using the prefix dosages, you'd give 6 units. Of course, that's not the most effective method because it doesn't take into account the high sugar before lunch, and overall, you'll still be left with hyperglycemia, which over time is detrimental. We can also do something called the prefix dosage plus the corrections. So we know he's given 6 units before a meal, and we can also calculate how much he needs to give to, in terms of insulin to get his blood sugar from 190 to 130. So if we consider the correction factor, the formula is the current glucose minus the target glucose divided by the correction factor. So 190 milligrams is what his sugar is. It should be 130, and we know that 1 unit will reduce his sugar by 50 milligrams per deciliter. So plugging this in, we get 190 minus 130, which is 60 divided by 50, and that's about 1.2 units. So we would recommend 7.2 units prior to lunch. Of course, they're going to have an insulin pen. It's not going to allow for 0.2, so realistically, they'd give 7 units prior to lunch. The third way, and the most effective but requires patient education, is carbohydrate counting plus the correction factor. So we know 1 unit of rapid-acting insulin will cover 10 grams of carbohydrates. If he's eating 50 grams at this meal, we know that's therefore going to be 5 units to cover the carbohydrates. So 5 units, but we also, as in the above example, that above calculation, know that he requires 1.2 units for to correct his high sugars. So if we put these two together, we get 6.2 units. Again, that would be 6 units. If this was an insulin pump, however, the latest ones are allowing the 10th of a unit to be administered, and it would be possible to give 6.2 units. But of course, assuming this patient is injecting his medications, it would be 6 units prior to lunch. Something else I would like to point out that's very important: when patients are taught to count the carbohydrates, they need to understand what is included in the calculation. If we look on the right-hand side of the screen, although it says total carbohydrates are 20 grams, as an example, we note that the dietary fiber is 4 grams. It's important to emphasize the patients to subtract the fiber from the carbohydrate, as that isn't covered by the insulin. Of course, we know fiber is not absorbed in the body. So on the right-hand side of the screen, the patient should be covering for 16 grams, not 20 grams. Okay, now another case study. We have a 22-year-old gentleman with a 2-year history of type 1 diabetes mellitus who presents to his endocrinologist for a routine follow-up. He currently takes 18 units of glargine at nighttime, and he takes 6 units of Novolog before each meal. He is compliant with his medication and checks his blood sugars at least 5 times per day. So very good patient, that's what we strive for. He brings a copy of his blood sugar log covering the past 5 days to the appointment today. So let's take a look at this blood sugar log. If we look at the glucose levels at 8 a.m., so this is when he wakes up presumably right before breakfast, we can see that most of them are quite high. There's 152, 118, 149, 150, 139. Remember, the American Diabetes Association recommend a fasting level of between 80 to 130. Although there's one normal level here of 118, that's more or less an outlier. We look at the remaining 4 days, and those are all consistently above. Let's go on to the next column. We look at lunchtime, which is more than 2 hours after the pre-breakfast dose. Again, none of these seem to be too discerning. The ADA, of course, recommends that a postprandial level would be less than 180. I would have no problem with any of these numbers in the second column. We go to the third column, again, 2 hours after lunch, so just under 2 hours after lunch, actually, it's 1:30 p.m. We see that the levels are all consistently below 180. If we go to 5 p.m. prior to dinner, again, this is about 5 hours since lunchtime, so this would more or less be in the fasting state by this time, and most of the levels are between 80 to 130. Again, we see one level of 134, and that's likely an outlier. We're not going to adjust the dose based off of one abnormal reading and 4 normal readings. Again, we go to the next column, 11 p.m. prior to bedtime, so this is about 6 hours after dinner. And again, the patient would be in the fasting state, and all the levels are between 80 to 130, nothing too low, nothing too high. So based off of this chart, I would say the most abnormal and only abnormal finding is the persistently high fasting glucose levels. It's important to note that the fasting glucose levels are covered by the basal insulin, the background insulin, in this case the 18 units of glargine. And the other levels we see throughout the day, if they're close to the mealtime, we know that's covered by the Novolog. So in this case, the glargine doesn't seem to be covering the glucose effectively. It needs to be increased. So the best option I would recommend is option C, increasing glargine to 20 units at bedtime. There's one other thing I'd like to discuss before we end off, and that is something called mixed insulin. It's not recommended to be used in type 1 diabetes because it's a fixed set of a intermediate or long-acting insulin and a short rapid-acting insulin. As we can see, there's multiple examples on the screen. If we look at the first one, Novolog 7030, also known as Novamix 30, that means there's a 70% of that drug is basal and 30% is bolus. If we look at this graph on the bottom, we see it's twice daily injection. The first peak in red corresponds to the morning administration and covers breakfast. We see the intermediate acting peaks throughout the day and covers lunch. And again, the second injection of the day will cover dinner and overnight. So with this administration, patients only require twice a day dosing. However, it's less flexible, and again, it's not recommended in patients with type 1. Why I've put on the bottom of the chart something called Rely On is because Walmart actually has their own brand of Novolin 7030, and for patients who are uninsured, again, the cost-effective management of diabetes, this is something you might actually see patients requiring. So let's talk a bit more about the mixed insulin. Novolin 7030, as I said, an example. 70% is intermediate acting, so NPH. 30% is going to be regular acting, which acts as the bolus. So how this works is 2/3 is administered in the morning and 1/3 is administered in the evening. So that comes to the end of our video. I really enjoyed this. Hoping for more videos in the next few months. If you want more diabetes practice, I've actually just released a textbook on Amazon called Essential Diabetes Revision. It's over 200 multiple choice questions in diabetes, examples like what was discussed in the video today. And otherwise, I wish you all the best and good luck with your studies.